In this case, the patient came in saying she had TM joint pain. But what really caught my attention was the facial asymmetry. For me, the challenge here is to correct the tilt, relieve the muscle tension, and do it without making her symptoms worse. You can't expand the upper arch without expanding in the bottom. Then you may end up with incisal edges not on the same plane. But the problem is I've seen very few patients that likes the look of an increased overgenital. Just by looking at this maxillary cast here, or the digital model, and you look at the height of the 2, 3, 2, 4 and the 7 there, comparing to that side, the 7 is more or less on the same side, but look at the low-hanging teeth on this side. And apologies, let's have a look at the bottom. Higher on this side because this side is higher, and I'll have to show you that other bite. And then, yeah, so the lower on this side due to the very hard contacts there. Apologies. So, with any case that you do, you can't just jump in and say, now I'm going to move the teeth, I want to align them. Orthodontics is orthodontic straight teeth, but it's all about establishing the patient with a balanced bite, equal forces on all the teeth. And that's what we have to look at. And how are we going to do that, taking into account aesthetics, and then at the end we want also stability. So my treatment philosophy is aesthetic driven, functional outcome with as most as possible stability. But let's look at the treatment. What are we going to achieve here? And before I can say that, apologies, I'm going to interrupt myself. We have to diagnose. So I'm going to give you the diagnosis in what I can, because I'm not showing the records. It is a class 2, you saw the open bite, a vertical grower, and with an open bite and a facial asymmetry. Let's put it that way. That's in short. Vertical, class 2, open bite. Difficult case to handle. And the moment you've got an aesthetic concern, it becomes even more difficult. So once we've got the diagnosis, we have to decide, how are we going to address this? There's an asymmetry. The maxillary plane is tilted, lower down on the left-hand side, up on the right-hand side. What are we going to do? So to sort that out, I think I'm going to do intrusion on this side, extrusion on that side, and then fit the mandible along with it. Intrusion with braces, doesn't matter what vehicle you use, either fixed braces or aligners. Intrusion is a difficult type of movement. So we like to make use of extra forces outside of the braces, and they would come into play the possibility of using a temporary anchorage device. I'll see how much intrusion I need to do. Then she's got a bit of crowding, a little bit in the bottom as well, not too much. So my goal that I've set myself here is to intrude on this side slightly, extrude here to get a plain, even level there. So let's take that away and let's see. I'm going to always tell this to you guys. Get yourself a reference tooth when you start planning your treatment. You need a reference tooth for the vertical, a tooth that's closest to the position that you want vertically, and that you need. Your maxillary incisor is always the one that determines your aesthetics, the position of the maxillary incisor. Look at the smile, look at the exposure of the gum, look at the tooth exposure, and decide on the vertical. Secondly, you have to decide on the transverse, that's just midline. Her midline is good. And then you have to decide on the sagittal, which is from antero to posterior, in that direction. Now she's a class 2, we've got an overjet. Are we going to close that overjet? I don't know yet. I'll see when I've lined up the teeth. But the sagittal position of the upper tooth is so important because it affects the upper lip, and you don't want to change the position of the upper lip. So in her case, she's got a good support of the upper lip. I don't want to challenge that, so I'm not going to take it back. Due to the overbite, I'm going to choose that tooth as my reference point in terms of sagittal. Slightly further back, it gives me less of an overbite because I'm going to aim to treat her. She said no surgery. I'm going to aim to see if I can do this for her without surgery. In terms of vertical, she's got a beautiful smile line. That tooth in all aspects serve the transverse, midline, vertical, as well as a sagittal position. And I'm going to lock it there. Where's lock? There we go. Now I know I have to work out everything around that. Let's have a look at the bottom. Midlines fit. So what are we going to use? In terms of sagittal position, so transverse is sorted out. In terms of sagittal, from the front to the back, she's got an overjet, but even if you don't have a CEF, I did my CEF, and I know that those teeth are quite at an inclination. I can't go with them any further forward. I'm going to try and do it non-surgery. That's my first choice, her first choice. So I'm going to choose the tooth that's most forward, that one. Let's, for safety, take that one. And the midline is on line. Vertically, let's see. So transverse, midline sorted. I'm not going to move that. Sagittally, I can't go forward with that tooth. Now I only have to check the vertical position. What does that mean? How deep is the bite? It's a good depth. I don't want to intrude in the bottom. And what do we have? We have a level there, but this side then going to have to need to extrude. Can I allow for that? Yes, I can extrude there. Let's just lock that tooth. By establishing your reference teeth according to your diagnosis and your planning, and that's another important aspect, is when you plan, do it get yourself a goal-orientated, or I'm going to interrupt myself. Let me put it more eloquently. In any treatment planning, especially when you do it digitally, you have everything to you've got everything that you need. There you go. In digital planning, you've got all the tools you need to do a proper goal-orientated treatment because you can visualize the end goal. It's so much better than doing fixed braces. So get your goal, decide what you wanted to do, want to end up with, and that's what I did now. Vertical, transverse, sagittally, that's what I am aiming for. So let's see how it's going to play out. My goal is to get those, balance out all the other teeth on that side. So that's for the aesthetics. Then functionality. We're going to address that as I move the teeth. For function, obviously one would love to have canine disclusion, which is important to get rid of any interferences at the back. And then anterior protrusion, when you go forward, that you also want disclusion. In a case when you've got not a contact in the front, your protrusion is not that easy, but still the patient can go into protrusion, and then you want no contacts. You want total disclusion at the back. Okay, and then the last one, stability. Yeah, we're going to have a problem with stability if we don't have contact in the front. Then then it makes it so much easier when you plan your retention afterwards. You know you're going to have a risk, much bigger risk of stability problems or movement afterwards. So then you have to address that in your retention protocol. So let's start moving these teeth around. Good. Let's start with the maxilla. And I said I need intrusion a little bit and maybe a bit of extrusion there. I'll do just quickly the vertical just slap them, not much. And what is that, what I see there? Aha, so I've got that's a point of contact that I said, a very high point of contact that I have to get that cusp in. Now I can intrude, but this tooth talk is wrong. The root is lying very far there. That's why we call that a plunging cusp. So purely by changing the inclination of the tooth, see how much that contact is alleviated. Let's just see how hard it was. Just by changing the inclination or the torque, it's already so much better. Okay, let's have a look at it from the front. And that tooth can come slightly out, and then I'm going to have to intrude on that tooth. No, wrong one, sorry. Let's do it with that one. Difficult movement. Let's see how much that was. Intrusion was 1.06, not too difficult. Intrusion of 1 millimeter with aligners possible. The problem is it's a terminal tooth in the mouth. I've got nothing at the back that's going to assist with the intrusion. So my mind is sort of shaping that I'm going to make use of a tad there. Let's continue. Now I'm going to just go into aligning the teeth, and I see I've already collisions. I have collisions. Braces, your forces are much higher. That's why aligners, the patients always say, wow, this tooth movement, I never ever feel it. It's hardly painful. How is it possible? Because the forces that we use with aligners are much less. So the patient really is so much more comfortable, much lower level experience. Sorry, I'm going to repeat myself. Aligners makes use of much lighter forces. So what does that mean for the patient in terms of comfort? Because of the lower force level dissipated over a longer period of time, not like initial engagement with wires, the pain experience, the amount of discomfort it causes the patient is so much less. But now you've got less forces, so your teeth will more easily get stuck. So you can't allow any collisions, which is going to make that tooth not move. So we've already got collisions here. We're going to have to expand there. So I know I'm going to have to distalize. The patient hasn't got wisdom teeth. I always check that out. And if there's wisdom teeth, I will always advise them that we most probably are going to have them removed. So let's just now I'm faced with something different. Got more or less same occlusal planes. A lot of detail still needs to go into there. But look at the inclination of the 4 and the 5 especially, a little bit of the canine too, and it's different from that side. So I'm going to address that too, because the moment I change that, it changed the expansion as well. It creates expansion. So this is called tipping. Actually, it's stalk, it's not tipping. What is stalk? Stalk is moving the root in the maxilla towards the palate, and the crown comes out. So it's palatal root torque. Palatal root movement is torque in the maxilla. I want to intrude it less because I don't want a flat curve. I want it slightly up at the back. it's very important when you submit a case or when you make your diagnosis. No, it's important to decide when you do your goal-orientated treatment, what are you going to do with the gingival line? In this case, I used a 2-1 as my vertical reference because the lip exposure, everything was fine. But now I have to decide what am I going to line up. This tooth is longer. Let's just get that out of the way. The 2-1 is longer than the 1-1. Let's just check. So I've got a much longer lateral there. Now I have to decide, am I going to line up the incisal edges or am I going to line up the gingival line? Because that's going to make a difference in my treatment strategy. If you line up the gingival line, if you ask the company, whoever does your design, or you do it yourself and you line up gingivally, then you may end up with incisal edges not on the same plane, and you're going to have to do either restorative addition with composites or change the shape to get them all on the same plane. Or if you line up the incisal edges, you're going to have a scalloped margin that's not in harmony, in balance. So for instance, like we can see here, let me just remove that. This lateral is so much higher. And that's not the aesthetic pattern that we use. Your central is always the highest, then your lateral is lower like this, and the canine is slightly higher, most of the times on the level of the central. So we've got a problem here. Let's see what is the reason for that. I can't show it, I can't say that it's definitely, but the chances are good. Let's just get them equal. That these 3 teeth has been, definitely those 2 teeth has got facets on them. They've been worn off slightly. This one, not that much. And it also seems to be wider than this one. So it's quite a totally different shape. If I look at these 2 teeth, they're square. And this is a long, narrow tooth. It creates an aesthetic disharmony. Let's see how the bite pans out. Then I'll decide if I need to address that in the aesthetics or not. The patient didn't mention it. Now I've got my transverse. I've established in the upper arch the vertical, transverse, and the sagittal. Let's see how we are going to fit the mandible and see the types of movements I need to do this. Midlines line up. The depth of my bite isn't bad at all. It's not an open bite, it's not a deep bite. How am I going to get these teeth to meet? Quite a wide maxilla, narrow mandible. Okay, I checked the gingiva, I checked the quality of the periodontium, healthy, lots of attached gingiva, type 2 periodontium, which tells me I can expand, I can accommodate this expansion I need here. No, I've got a problem here. Let's just see what's going on. Extrusion 1.5, distalization almost 3 millimeters. That's a lot. Yeah, good. Tells me I'm in for a difficult treatment. Okay, I see that's my reference tooth. There was lots of gingiva. I think I'm going to go for that one. Just makes it easier. Not easier, but patients don't like an overbite. They say they don't want surgery, but if you increase the overbite, they always tell you, but this doesn't look good. So I want to give as small as possible in my plan I aim, I'll see how it works out, but I don't want a massive overbite. So it seems to be not too bad a contact point, but then you start wheeling it around and you see, but it's not good. And there we go. The reason is the tooth is not in the correct, hasn't got the correct tip. Fixed. Again, I'm faced with incisal edges versus gingival line. These teeth are really, really short. But composites and veneers on mandibular incisors is not something that lasts. So I'll just allow for reshaping of that tooth, just giving it a slide of a bit of a longer edge there. Still have a tip on this crown. Look at the shape. And the reason is most probably due to, the length. That tooth is so much shorter, so the contour is different. I'm going to battle to get it into the right position there. And I'm not working on that much on detail now, so let's just move on and see if this plan is going to work before I spend too much effort there. Always check all the relationships from every possible aspect, rolling it to see what's going on. Good. Got a poor contact there between the canine and that one. We'll sort that now out, but I still have collisions. So let me first create the space here. I'm going to have to distalize if I want to get rid of this. So let's just first see. And I'm curious, where am I getting with my contact points between the upper and the lower teeth? Because that's the last point, is the stability. And I see trouble again with the 7s, torque changes, intrusion there. No, that's extrusion, yeah. It's going to be a lot of hard work. This one is not creating a hard contact, but this side is, so something is off. It should be equal because I work symmetrically on the left and the right hand side. So let's try and establish where did I go wrong. Poor contact there. It tells me that crown is too far, root too far moved back. That's starting to look more acceptable. It seems that there's composite there, and I wonder what it is. She had previous set of aligners, it may be. So let's just check. Yeah, and there you can see. Let's just look at it. You can see the composite there. I'll have to go back and remove that. Let's just a short note on how aligners work. While braces, you've got your brackets on the outside, you put in a wire that's slightly wider and a pull. And that's why you don't need microspaces. It happens by itself. With aligners, the aligners, the material push the teeth. So you've got a different way of the teeth to move. So you've got pushing, and then secondly, adherence is how the aligner, how closely it fits to the surface of the tooth. And those two things, it push and it have to fit close to give you your forces, which are much lower. So you want predictable results, so you must make sure that your adherence is good. If I remove the composite from this tooth as I did now, and I'm just going to remove it in the mouth without scanning, I may end up with less adherence on that canine, which a canine is for me, besides the maxillary lateral central, the canines are the most difficult teeth to move. So I'm going to make a note that I have to rescan this case if she accepts treatment. Everywhere I want proper adherence. So let's just have a look at it from the front. And I don't know, I thought I had my height sorted out, and now it seems to me that I've got a not. That doesn't make sense. Ah, there we go. Now I've got it out. Good. I had that canine sorted out and I have a collision again. So let's just go back there and let's get the bottom jaw to fit. That was where I was. I was busy with that hard contact. Now my canines are on the same height, and let's just check now the contact points. Still a bit hard, so I've still got some problem to solve. Still don't have it. It fascinates me. I always believe that if you treat symmetrically, you're going to get the same contacts, but obviously something is not working out. If I look at it, that canine is either less out buccally, because there's less of an overjet than on this side. So it's going to be in my symmetry. Let's just bring this tooth slightly in, root slightly in, and let's see. Okay, I do, but the tooth anatomy there is disturbed due to the filling, weird shape, everything. So I'm not going to be dictated by the anatomy there. And I'm going to have to get this molar in. In fixed braces, we have the 6 keys of occlusion of Andrews, and I'm not going to go through all of them, but one of them, that's the marginal ridges must be on the same height, which is important for the bite, for the forces to be equally distributed, and for stability afterwards, to get proper landing spots for the cusp of the upper teeth, or upper or lower, wherever they fit in. So I've got a discrepancy here. And I need to sort out, where is it? The bottom, I'm going to have to bring this one up. Doesn't look, something is off. Okay. Let's cover it up with gums. What I can see is off. I've got much more chalk on these buccal teeth here than on that side. And that's why it shows that it's in there. So I'm going to have to fix that quickly. But let's just first have a quick look if this is an acceptable treatment for the patient or not. It's still off. How am I going to decide whether this treatment is possible? I have to see how much tooth movements I need. Firstly, just to get the teeth there. Then secondly, I'm going to have to judge, is it possible to do that with aligners? And if not, can I make use of any extra auxiliaries to add in to help me to make the teeth move? So let's have a look. Let's start with the upper. Okay. Before I do that, I can't really follow the tooth movements. I'm going to have to work it out and see how many aligners are needed, pull the force, pull the liner length the treatment is going to be. 1/7 needs 16 aligners, 1/6 less, 1/7, 17, 1/6 less, 1/5 need quite a lot. There we go. Two, 4, substantial movement. 2, 3 as well, less. It's a lot of collisions I have to sort out, but that's, once I've got made up my mind what I'm going to do, then I will look into that. I know the 3, 4 needs most of the movement, so let's, okay, not too bad. 3, 3. I said that I do my planning in 3 stages. The first stage is I do move the teeth to the final positions. While I do that, I give a little bit of attention to detail, as you saw I did, sorting out the maxillary tilt, etc. But there's still collisions, there's still micro spaces. I don't do all the detailing because that is still going to change as I move the teeth along. Then the second phase is where I do the staging. During this phase, you recall that I already has lengthened these lines to get everything black, where once it is, or as long as when it's red, there's not enough liners. So determining it to that 15 there means that I need 15 aligners according to the global settings. But you can see there's a lot of collisions and that needs to be sorted out. And the same for the bottom. And I need micro spaces. And I need to check the occlusion. What I did in terms of the occlusion, I wanted to see that there's at least some sort of a stable contact point, landing point for the maxillary, palatal cusp, mandibular, buccal cusp in the central fossa line. And not on a ridge or it must be in the depth or in a solid point, the lowest point. So that I've did. And the other question I had with this patient, am I going to have to do surgery or not? So let's finalize that, determine the need for surgery or not, and then I'm going to end up this video, and then I'm going to do a number 2 where I'm going to do the staging. The staging is, although I've got the stages here, let me quickly fix that one. Although I have the stages in terms of the number of aligners, this is the minimum. The staging means you have to unravel the teeth, move them in groups or certain ones before the other to make sure there's not collisions or that you don't burn your anchorage unnecessarily. And then the last phase is to your attachments, and that I'm going to do in video number 2. So let's quickly check the surgery or not. So what I have here, that's not the final, that's better. Let's see what I have. If I take the labial aspect of the 1-1, this is just arbitrary, and I look at the mandibular incisors and I check the mandible originally where we were. That doesn't give me the right indication. So let's look at it from there. The patient was happy with this overbite, the size there, and that's where I ended. I think it actually looks slightly smaller. So I'm happy with that. If she chooses not to have surgery, I haven't increased the overbite. If a patient comes in with an aesthetic complaint and they want the upper teeth only aligned, the upper front ones slightly misaligned, you can't expand the upper arch without expanding in the bottom, and they're requesting only upper arch treatment. So you're restricted. If you expand the upper only without the bottom, you're going to end up with a bite that doesn't fit properly, or you change the bite and the patient may become uncomfortable in the way that the teeth comes together. Secondly, you risk of creating interferences and TM joint problems or MPDS. So you have to keep the contacts at the back the same while aligning in the front. And where are you going to get that space? By anterior expansion. Can give the patient extra lip support, but the problem is I've seen very few patients that likes the look of an increased overjet. Bugs Bunny, they just say, I don't like it. And if they really set on it, you're going to have to take those teeth back for them. So double check on them. They must know that they're going to have an increase in overbite and almost sign that off for you. Okay, that's on the side. So let's look. We didn't increase the overbite. We actually made it smaller. So the patient is going to be happy with that. What does the contacts look like? They're sort of in the depth of a fossa. I'm not sure about that one. So let's check what it looks like. There's high contact. That's going to be uncomfortable. I'm going to have to change that. Okay, that's detail in the occlusion that I can do later on. And let's see on this side. I've got contacts on uneven surfaces. So I'm either going to have to play with the buccolingual position of these teeth, or the patient is going to have to be equilibrated if she refuses surgery. What are the chances for surgery? If I can tell her that's a better choice, I am going to show it to her. So let's quickly do that planning. I've got this facility here. I'm going to go for molar and premolar contacts, and I'm going to move the jaw forward. There's going to be a bit of post-surgery orthodontics to make the teeth fit in. I'll have to change slightly and get more torque on my anteriors to move these teeth further back for a surgery option, but it's not possible. So that's a good one that one can do. So I'm just going to save it like that. And let's see if we go there and why didn't it save? Smooth shift 178. Let's do a smooth shift and see. And the software is bugging me. Okay. Nevertheless, it's a 1.78 move to get the jaws into that position. And I'm going to choose that one again. There we go. I think it registered it now. Oh, there we go. So there we go. Now from here on, post-surgically, I'll actually in my initial treatment already sort this out. But I'll present this to the patient and she can decide which one she chooses. That's maybe too far. I prefer much better overbite, overjet and overbite than that. Good, that's sorted. The question was, is it going to be a surgery case or not? I'm willing to give the patient the choice and say if she don't want surgery, I'll definitely indicate to her all the downsides of that. Overbite, not stability on the front teeth, and we will have to equilibrate slightly on the back teeth. And then the choice of surgery. So let's take that away. And then types of movements, let's just see. Upper arch is not too bad. Bottom one, I recall this premolar here. There's still some detailing to be done. Let's just quickly check the 3, 4. According to this, only 17 aligners. I must say, I'm surprised by that. I thought it was going to be much more. Okay. I will specifically, in a case like this, with this amount of movement and starting off with a crossbite. Let's just, I wanted to show something else as well before we finish off here. Remember I said that I did a, what you call the CR, first point of contact bite, and that's why it's open there as well as there. The patient said the midline stays on, and when she goes into maximum intercuspation, it's exactly the same. So let's just quickly check what the bite looks like if I should have treated it then. And it's this one. There we go. Slight midline off, so she moves the jaw slightly over to get rid of that contact point there. So there's a slide to the left, and most probably, look at that. Look at that slide there, the difference. This is amazing to see. I'm also only looking at it now. I love this. Good. Let's have a look at this one. Take it to the original and let's. So much more symmetry there. And that's a complaint about the asymmetry in the face, is the jaw, the shifting over to that side. Do you guys see that? Look at that. Wow. Okay, but I can fix this as well. What I wanted to show is this crossbite here. I need to be aware of that once when I start treating her, that can prevent the teeth from moving. And this position as well. I told you guys she had aligner treatment with a previous orthodontist, and she had 3 sets of aligners, and I checked all the setups, and she had that crossbite from the beginning to the end. It hasn't been fixed.